Okay. So this is kinematic parametric. So the purpose of this surgery is reproduce the patient's native articular surface using the component. As a result, the components can be aligned in the three axes. One is the tibia flexion extension axis around the knee. No, so the femur component. So we call it condylar axis, not epicondylar axis. So that means the center of the medial and the lateral condyle and the line between the two centers. That is also called as cylindrical axis. So, and the second is now. So everybody knows about the first axis very well. So that's why for the kinematic RME user tend to use the single ray component to reproduce the first axis. The second one is now focus to move to the second axis. That is the patellar axis. So theoretically, patella move around this red line. This locates a little bit anterior and superior. So around this axis, the patella move superiorly and inferiorly. But now, so far, the first axis has been focused on, but now our interest into the second axis. Of course, this one is decided by the height of the trochlea. So the group should be reproduced the previous one. But now our technique is flat surface technique. To anterior cutting line should be the same or slightly anterior to the bony surface of the here. So femur anterior cortex of femur. So never make nudge, but never too high. The idea is to flush. Cutting surface should be the same level as the anterior surface of femur. But in some case, the thickness on anterior flange is too thick. As a result, so this trochlear group can be different. You understand? So if the trochlea is too inferior, too deep, to be, so effect of the quadriceps, so getting down, to the decreased labor. You understand? So, but too high can cause stop or tightness of quadriceps can decrease the flexion. So ideally, not only the cylindrical axis, but also the second axis should be reproduced perfectly. So not too high, but not too deep. Ideally, it's the same level. So now I try to cut the anterior branch of the same thickness of the components. So I measured the persona anterior branch. That was around 6 millimeters. So if we cut the anterior branch and major thickness, maybe 5 mm is ideal. Okay. But and they insist that the patella move around the second axis. The patella motion is perpendicular to this axis. But actually, this movement, this direction can vary among the patients. Some patients is perpendicular, but some patients move slightly lateral. So it is very variable among the patients. So ideally, this branch anterior part of the femur component should be changed according to the patient, the kinematics. So ideally, it is ideal if I choose the direction of group. So media one, center or lateral. So so-called modular type. This one and this one, we can select freely. That is the idea. But it is impossible so far. But in the near future, from the Metacuta, they will release the new type of camera component that is suitable for the kinematic dynamics, that is wide group. So any direction can be allowed because of the wide range. Okay. Anyway, so the second one is also important. Second axis is also important. And the last is third one. The third one is the tibial rotation axis. So theoretically, so tibia rotate along this, the third line, the third axis. So medial side is stable, but the lateral side move anteriorly and posteriorly. So-called medial pivotal motion. But in fact, so medial side, this axis not so stable, I think. That can move anteriorly and posteriorly during the knee motion. So I think this is not straightforward. Some patients shows the center pivot, and some patient shows the lateral pivot. So that is maybe that is frequent in the patient with the lateral arthritis, maybe. So this is the one type of kinematic, I think. So there is a two options to use the medial pivot component and fix the medial contact on the polyethylene. They never move anterior, only allow the rotation. And furthermore, medial side is a single radius. Now that should be the idea. But in my opinion, the medial pivot is not for everyone. Some patient has center pivot and other patient have the lateral pivot. If the patient has the central pivot, or so it media contact move anteriorly, posteriorly, around 1 centimeter or 1.5 centimeter. So if we use this type of component for such patient, so maybe some conflict between the native kinematics and this conformity constraint of this component can cause conflict, as may some stiffness and discomfort, or instability, loosening of bone and tibia component.
Is there any way to find out where the axis is pre or?
Oh yes. So another one. So So another selection is media size is also flat.
Media
So,
size is also.
so CR,
Okay,
flat,
CR,
CR. So not only the lateral size, but also media
Yes,
size can move anteriorly, posteriorly. I don't know which is the better. Maybe we should select based on the patient kinematic. So because using the Oxford knee, so in the Oxford knee that has the intact ACL and intact lateral, the media are in such situation. But that is a virtually normal situation, but the media can move anterior posterior around 1 centimeter during the motion.
No, in your personal experience, what have you felt? The patients are better with the CR or with
I have no answer. I have no answer. I don't know. Each one has advantage and disadvantage. No. The for disadvantage of CR component, basically TKE is ACL deficient. So this knee is unstable itself. So we need some constraints, so some restriction of movement. So in this purpose, so this media side high conformity component is reasonable to stabilize the anterior and the posterior movement. And in the same time, in the ACL deficient knee, rotation motion such as screw form movement, it can be destroyed. So once ACL is damaged, so we can find pivotal system option. So anterolateral subluxation of tibia. So that can also cause some instability. That is the disadvantage of TKG's ACL deficiency. We should stabilize at least anterior posterior movement. So that is this is the better. We are thinking about ACL deficient. But when I think about the innate kinematics, even in the ACL its functioning is media contact movement series. But so far I have not. So I use the both media pivot, so micropod and metacenter, and a marriage radius for the Zimmer biomet. That is, Zimmer biomet is also media pivot, but not so conformed, perfectly conformed. That allows a slightly anterior posterior movement. In my impression, but no evidence, marriage radius is better. Yes, maybe so. Range of motion is better. So I think so. Tight flexion is not good for the high flexion. That can restrict the knee flexion. もう、なので、じゃあ、行ってきてください。はい。
でも、キネマティックなところで、グループの動きでもある。
グループ、何が何が動きはだから、一旦トライアルを入れて、その動きを見ると分からへんのちゃうかな。ただそれを選ばれへんから。
だから、
だから、そのグルーブの向きに合わせて、一つは、ここの部分だけ選ぶっていうのも一つやけど、それは現実的やないから、じゃあ多少、こっち向きでもこっち向きでも、いけるような広いのを作ろうかっていうのが、そのメダクタのコンセプト。 あとはもうこれをミディアルピボットで内側をきっちりキャプチャーするべきかどうかっていうのは分からへん。理想的にはこうなんやけども、本当にこうするのが正しいかどうかっていうのは誰も分からへん。
メディアピボットをしっかりがっちり固定しきるかどうか。
うん。で、メディアルピボットがその下でナチュラルかどうかっていうのはもう分からへんからっていうところ。Yes.
I am a predominantly PS surgeon. So can kinematic principles be done in PS?
I don't know. I don't know. But theoretically,
Sorry.
PS is not for KA because
Because
so
theoretically,
yes, the sacrifice and basically the PS component is the center people.
yes, because of the box
Not
and the
yeah, not the media people.
Hmm.
So maybe PS user should use functional alignment.
So
Functional alignment.
can you just
Functional.
briefly can you tell the difference? I tried searching, I'm not able to understand the difference. Like kinematic and functional. In kinematic, we are just resurfacing the damaged node.
Yeah,
Getting into the pre-arthritic state.
But
In
if
functional,
you sacrifice the PCL and resurfacing, in some patient, pressure gap is too loose. Once you
PCL is-
cut PCL. So it is similar to the
But we take
gap
a-
balancing.
But we take lesser slope. In the
Mm.
CR, we take around 7-8 degrees.
Yeah.
In PS, we just take 3 degrees.
Yeah, understand it.
So fraction gap will
Yeah.
be managed with that.
So you mean so reduce or posterior
Posterior
slope
Yes.
or reduce or the posterior cut thickness.
Yes.
Yes. It's a similar to gap imbalance is adjusted by bone cut.
Okay.
Yeah.
it is
So
functional.
that means the gap balancing technique. So bone cut is decided and based on the gap.
That is functional.
Yeah, this is a kind of functional alignment. This is a functional approach. There are two streams of TKA. One is anatomical approach that originate from the UKA or by UKA. Then connect the medial and the lateral component. It will be one piece.
Okay.
Then it evolved to the resurfacing CR knee. Another stream is originated from the hinge knee. So consider the knee as a hinge joint.
Yes.
This is evolved to the rotator hinge, then comma post. This is half of hinge, not a perfectly constrained hinge knee. They can allow, they induce the flexion extension, but not perfectly connected.
Yes.
Only restrict the posterior movement. Yes. Then that is the now it is a PSE. So the three and the philosophy is completely different between the CR and PS. But now every component have the both
Different.
CR, no, the CR, so
But
the
yes,
environment, the pure,
Everyone.
for everyone. So many surgeons misunderstand that. The
Yeah.
difference, only difference is sacrifice the PCL or preserve the PCL, but completely different. So concept of PS is destroy the need everything. And so the build a new need. So by the mechanical stability and the program the kinematics. That means engagement the command post and design of command post shape. The more kinematic can be decided of the design of the engagement of
Okay, of course.
yes,
So
yes,
high-flex design.
yes. And that's why so PS user should use the gap balancing. Once,
Oh, yes.
yeah, sacrifice PCL. So in most patients, the fraction gap enlarge. But so this the enlargement distance of enlarge different among the patients. Some patients more than 1 centimeter. Some patients never change. So one sacrifice PCL and check the fraction and extension gap. Then decide the posterior slope and posterior cut thickness and the rotation.
You have to
So
totally.
that's, yeah. To the final goal of TS is create the balance gap in extension and flexion. And functional alignment, not only the flexion and extension, but also mid flexion and deep flexion. Deep flexion and mid flexion in the all range of motion.
Mhm.
So for this purpose, we need the computer device.
Mhm.
But using the manual instrument, we only can only adjust extension and flexion.
Mhm.
So now PS is that destroy the house and build a
Rebuild it
new
again.
building. So and CR is the reforming.
Yeah.
The frame, retain the frame, and then change the wall and door and window. That's all.
The thinking process is totally different.
Totally different. So
That's
different.
why you don't care.
Yeah. So we call this kinematic alignment and the functional alignment. We call all together to the personalized alignment. That personalized means we are aiming for the patient best situation. What is the best situation? So balance gap, or that is the functional alignment. So resurface, so recreate the patient native anatomy, morphology. That's in a kinematic alignment. That is, yes.
So you resurface, that is kinematic.
Mm.
Then if there is some amount of gap balance, you balance it. That is personalized. That is a
Yes. But they believe that, kinematic user believes that if we perfectly reproduce the patient native morphology,
it should be.
Gap balance can be adjusted naturally. So they accept a slightly loose lateral.
Oh, so that's why you don't care about somehow.
Yeah. So, but functional alignment concept, if the patient have a lateral looseness, that can be corrected by the bone cut. But even in the functional alignment, the slight lateral loosening can be allowed. But which degree lateral loosening can be allowed? Nobody knows. Maybe, in my opinion, not only the alignment, but also gap imbalance. There is the boundary safe zone. So we should find the boundary or safe zone of alignment. So, for example, 5 degree or 6 degree, 3 degree, what is the boundary of the various alignment? And in the same time, which degree of the lateral looseness? Also 10 degrees, 5 degrees, or 2 millimeter, 3 millimeter. Nobody knows.
There is one paper in which they have mentioned, I think it's a UK paper, lateral 2 degree to 2 mm.
Yeah.
Within the period of 6 months, it resolves by itself.
Yeah.
So up to 2 millimeters, you can safely leave in 6 months. It resolves. There's one, I think it's a UK paper.
Yeah. Yes. So, but it is another. So next another goal of our research in the future. So we should find. So in our experience, based on our experience, the alignment should be less than 3 or 5 degrees. This is only our feeling, but no evidence. So kinematic alignment user insists that 8 degree, 10 degree doesn't matter, as long as you reproduce the patient native morphology. But in the same time, in the feeding, 3 or 5 degrees of lateral looseness can be allowed. So that maybe so we need a lot of data. So data, intraoperative data and postoperative data of alignment and gap. Then we should compare the laxity and alignment data and result or outcome of patients in so many. So in a limited number, in insufficient, I think. In one institution, only the 100 or 200. But to find the final answer, we need 10,000, 1 million data. So-called big data. Because this boundary is not only one. Maybe it can change to according to the gender and the age and the races.
BMI.
Yes. So to find, it's we need very complex analysis.
Yes, the data is more better.
Yeah. So that's why the robotics is very important. So using the ROSA user. Once I use the ROSA, a lot of data, the both alignment and gap can be stored in the ROSA.
Even the full
And yes, yeah. And the environment have a lot of data about this. But problem is the data are only available for the environment. The core data is only available for Smith and Nephew. Or there are no communication of the data.
Yes.
If we can use all data at once, then it's better. We can move